We usually try to make it as a bridge because it gets support from two implants. That is what we do. That's the common protocol we follow. Unless where very good aesthetics of the patient is not satisfying, we can go for two. These are multiple implants. Since these are all in various areas, I told you the basic principles, anatomic considerations, and everything. You can go for implants. You can see in the molar region, there is very little bone. See, when there is very little bone in the sinus region, for example 5 mm, you are choosing an implant size of 6.25. You have to go for about 3-4 mm, then give a bit of a gap, allow the bone to expand, then tighten it with a wrench, slowly. Okay, so normally it pushes the sinus above. Another way is when there is even more lesser bone, you can put some graft into the socket, then you can put the implant and slowly push it. That itself will do a sinus lift to an extent. And it is a totally, there is no bone at all. In some cases you find, no, the X-ray will show you there will be the ridge immediately sinus. In those cases, you have no other option than to go for other bone grafting techniques. When there is about 5-6 mm, easily you can push it a few millimeters above using these implants by bone grafting and gradual tightening of the implant. So this is another anterior implants. Just put some pictures. Any doubt somebody can ask. Another thing, what is the, because in smooth surface you won't have any clogging of materials or food particles there, and it doesn't cause peri-implantitis. That is why you see in single piece implant system we call, no, the upper surface will be smooth. In zygoma implants how it is. Only the end portion will have threads. All the other portion is smooth because you won't have infection. Materials will not go in. So you just trim it off in a smooth manner, very carefully again, those micro vibrations should not spoil the implant, and then you can go ahead with the thing. And when you go for the crown, take a beautiful impression up to this, and you can finish. And the impression is again another issue. We can't give all the concepts in one shot, 1 minute time. So this is another beautiful patient, 3. We have supported it as a bridge as well. The angulations are taken from the next teeth. This is an RPD initially. So as I told you, multiple teeth where we have used it as a bridge here. So implants, you can see it always put it a little below the bone surface, compensating. In the end, I'll show you a 5-year review of a patient as well. Yeah, she came in accidentally a couple of days back, so I utilized the opportunity. There's a posterior implants we have done. It was done about 5 years back. So this is the first X-ray. Beautiful. After 5 years, there was a little bit of resorption. But since there was an RCT here, we have already bridged it with that. It is. The advantage of implant over normal FPD is, in case we don't load a bone, it resorbs. In FPD, always after years, the bone resorbs and patient will complain of foot entrapment or other thing. It's just like exercise. You load your muscle, it stays. You don't give any workouts for your muscle, there is atrophy. Same thing with the implants as well. So this is a particular patient's credentials here. And you can see it's very close, and again about at least 5 millimeters above the nerve region it should be. I had an instance years back where I put an implant, the next day patient complained of a mild paresthesia, nothing to worry actually, you can unscrew it a bit and take it above. It usually resolves immediately. And don't try to, when the patient gives you a symptom, never try to neglect it. It will always be there. If the patient says pain is there, means it will be pain. Most people, they say, everything is okay. When there is pain, patient comes to you again and again saying there is pain. And if you don't respond properly, patient is going to go back to another dentist for sure. 2-3 times they'll come, and then they just go to another place. Fix. Another single tooth. There's an immediate temporary. Stellan is very good in that, immediate temporary. So now, there are 2 things. One is cement retain. When we start, cement retain is easy. You put the implant, put an abutment above in a proper angulation, take a nice impression, and go for the crown, cemented. Then, as the time goes, when you expertise, you can go for a screw retain. What is the advantage? The screw comes on the lingual region, as you can see. If there is bone on all the region, very simple. Go for maximum number of implants, 6 or 8 implants. If there is less bone on the posterior aspect, that means you can't put implant there. Go for all on 6 concept up to the first molar. If there is very little bone up to the molar and the premolar, first premolar region, go for 4 implants. It is called as all on 4. If there is no bone all around, only there is bone on the anterior region and less bone on the posterior region, very simple. Something big you need that. They say pterygoid implants, I have not tried. You can go for zygoma implants. You can go for patient-specific implants also. That is more towards the oral surgery. People, it's easier for us. Other people are also doing that. So usually we load it between the first molar to first molar. So once we put the implants inside and allow for a healing period, you have to add the abutments, check the angulation, and then you will have to initially make a jig trial made of a resin, and then once it's in the proper format, it comes in, and then it comes for a metal trial. Any error is there, the work is going to repeat. This is the problem. Over a period, you will master it. So this is the screw retain. This particular patient, we made the Malo type of bridge, where we gave individual crowns. We added the gum also, and then individual crowns, that is for 12 units with the resin. This was a peak material which we made. We have a lot of materials. So basically, when we have multiple implants, to increase the success rate of the implant, what we should do? Give more support for the implants. How we can do? Just like our bridge, where we do, you give more support. Implants are pillars, and then above you give a support which is called as a metal framework. So for this formation of a metal framework only, you make a jig trial initially. That is like a wax or resin, and then you adapt it. If everything is okay, go process and come. The metal framework is ready. From the metal framework, you can do it in different concepts. Suppose the ridge height is very less. You have to increase the height of the ridge. You can go for a denture type of implant retain prosthesis, where it is just like a denture, where there will be no flanges, but this abutments will project from inside. You can either cement it, or you can put a hole above and go for a screw retain. That is one variety. Another variety is you want individual teeth for each of the for the patient wants individual teeth. He wants zirconium crowns for everything. What we and the patient desire, zirconiums are very important. So we put the individual crowns. What will happen is from the metal framework, you have individual projections like tooth. Over that, you cement it. So you wanted to retain some good teeth, so that's kept for satisfaction until they fall off. So this is a very nice patient. He's no more actually. He's an 83-year-old man with severe cardiac issue. He wanted this to be published in the paper also. He wrote and gave the put a signature also from it. We were very tricky to treat him. In between, he'll not come for a month. He'll say, I was admitted in the hospital, and again he'll come. We were very worried, but finally finished. We did the all-on-4 concept beautifully for him. That was his desire. So teeth are not just for the young people to smile upon. Even the old people want to look young, they want to eat well. That is why they can come with so many complications. We do for a lot of patients above 80 years old, full mouth implants, they're willing to spend so much for that. And the last, that's for the credibility of the oral surgery where I belong, something which is very easy for us. See, in some cases, it's completely resolved, there's nothing. So what we can do is go for a patient-specific subperiosteal implants. So I'll show you the design. So this is on the mandible. We'll have projections. Inside there will be like the plating system. You put the screws, fix it properly. You have to do a CBCT in the DICOM format. It is printed in CAD/CAM, and we did. And recently I did an eye surgery also like that. There was a patient who was having a deformity in the orbital floor, which we did. So this is how we do. So it is designed like that. It's quite an extensive surgical procedure for the other, but it's fantastic if it works. But now, even I don't do immediately load it. I give it at least a month's time now to load it so that you're quite stable. And then you can just cement the thing. This is on the post-trauma patient. This was the only option. Even the zygoma implants were incorporated into the framework. So I had to make an infraorbital incision. The upper portion can be done like that only. The infraorbital rim and the lateral rim. And then the implant system was loaded. This is the other person, This is another patient where both the molar regions. Okay. So when we have in between checks can be done like this. You can put the implants before loading. You can add these, transfer copings, take an X-ray and check how is the parallelism. You can get an idea. Same slide. So that's all some basic concepts of dental implantology, and definitely this is going to replace the crowns fully. It is obviously 50-60% it has done. And since more and more of us should do all these procedures, then only they'll get publicized and everybody will resort to it. Any procedure is like not one person doing, everybody doing. And it really increases the awareness of the patients also that this is the right method of treatment and motivate them. Thank you so much for the opportunity for the ideas take office.